Well, good afternoon, everyone, and thank you for being here. Welcome to the National Hispanic Council on Aging's Health Equity webinar. My name is Yarisa Reyes, and I'm the National Director of Diversity, Equity, and Inclusion Engagement at the Alzheimer's Association. It is my pleasure to moderate today's virtual event, which is supported by Biogen. For more than 50 years, the National Hispanic Council on Aging, or NHCOA, has worked to improve the lives of Hispanic older adults and their families and caregivers. NHCOA's commitment to their mission has only been emboldened in the face of the ongoing health disparities in our communities. During today's webinar, we will have a panel of experts that will present key concerns regarding cardiovascular illness, adult vaccinations, Latinos' participation in health research, and Alzheimer's disease and its impact on the Hispanic Latino community, as well as potential solutions to address those concerns. To begin the virtual event, it is my pleasure to welcome and introduce Dr. Monica Mann, the Vice President of Medical Affairs for Global MS and Pipeline at Biogen. Dr. Mann brings 21 plus years of experience in immunology, neuropsychiatry, and genetic diseases, and recently celebrated her 10-year anniversary at Biogen. She is the current head of early to late stage and mature assets over multiple therapeutic areas, including multiple sclerosis, lupus, stroke, movement disorders, and until very recently, neuropsychiatry. Since joining Biogen in 2012, Dr. Mann has held roles in increasing leadership responsibility and served on several diversity, equity, and inclusion forums to ensure internal development of diverse talent and external access to Biogen's portfolio of therapeutic treatments. Today, Dr. Mann will provide our welcoming remarks. Please help me welcome Dr. Monica Mann.
Thank you so much, Ms. Reyes. It's really an honor to be here on behalf of Biogen, where we aim to develop and deliver meaningful therapies for people worldwide living with serious neurological, immunological, and neurodegenerative diseases. At Biogen, we are committed to our employees, environmental sustainability, and of course, diversity, equity, and inclusion. And it is our goal to educate and empower all patients so that they have access to quality care. As an immigrant and someone who's had to help countless family members navigate the complexities of the healthcare system, everything including access to care, treatments of challenging diseases, and just simply connecting to caring and trusted healthcare providers, today's topic is extremely near and dear to my heart, and I'd really like to thank the organizers for having me here today. So when we think about innovation and drug development, we often think about this really as from the context of access to care as one of those critical components to innovation. As we all consider the ever-increasing diversity in our communities, it's pretty clear we need to have better representation in our clinical studies. And at Biogen, we are not simply enrolling diverse clinical studies, but rather the goal is to have data across different patient profiles to facilitate a better dialogue between patients and their providers, regardless of identity. This is fundamentally a group effort, and it's really the partnership with healthcare and patient communities and organizations like this that ultimately ensure representation in our clinical studies. And this includes everything from gender, geography, race, ethnicity, sexual orientation, and even military service. We're focused on bringing practical approaches to embedding a diversity and equity platform as we think about product commercialization, access, and launching strategies. This can include everything from seizing an opportunity to identifying and resolving challenges in implementation and solutions to providing quality care and access to treatment. And I'll talk about two examples of this with our lupus and our Alzheimer's program. In the lupus program, we have an ongoing phase 3 study of a product called BIT59 in systemic lupus erythematosus, or SLE. This will evaluate the clinical efficacy and the safety of this asset, this program, compared to placebo. And we have set enrollment targets within this clinical study to reflect the high prevalence we see of SLE in Black or African American, as well as Hispanic and the Latino communities. We also have a phase 3 study of BID59 in cutaneous lupus erythematosus, or CLE, and that has just received its first patient in. We're expanding lupus clinical trial site locations into communities historically underrepresented in clinical studies. And we also are developing an infographic called Enabling Health Equity in Lupus to really highlight the impact of lupus on underrepresented groups and the impact of social disparities on the disease course and long-term outcomes. We understand that improved outcomes in patients starts with a recognition of the health issue needs and those ensuring a connection with a healthcare provider. And we've done other partnerships that have launched a clinical trial index with the NHCOA that's comprised of US heat maps by patient demographics mapped against site locations to really identify the right clinical trial sites in the locations that allow for best enrollment. This index and heat mapping of a real-world data set has informed site selection for a lot of our programs and studies, both in lupus, Alzheimer's, Parkinson's disease, as well as stroke. By leveraging this index, we're able to build a clinical trial learning communities platform that consists of a network of both practices and community leaders that work together to promote clinical trial participation of underrepresented patient groups. And in Alzheimer's, we have the collaboration with ASI in the Clarity AD study. This is a co-commercialization and co-promotion of the study called Clarity, where we're making progress against our goal of increasing diversity in clinical studies, with a goal of 25% of Clarity's AD total US enrollment, including individuals from underrepresented populations. The conversations that happen between both patient communities and their physicians really starts with data, and we know how critical it is to collect these data through these formats. Through this work, we're helping select sites with diverse staff located in communities of color with access to diverse patient populations. We're also ensuring that there are comprehensive site trainings on diversity, equity in clinical trials, as well as educational materials for sites and added support so that they can conduct their own community outreach and engagement. Again, group effort. This connection is so important if we want to build a healthy and trusted partnership. So I'll close with a couple of thoughts. When you think about all the different aspects that bring innovation to a community, you see how all of us, regulators, drug companies, patient advocacy groups, and patient groups, have all the same goal in mind to bring more equitable based approaches to care, all of which have different approaches to get there. So like the topics that you'll hear about today, these are fundamental in bringing forward change and access to care. And with that, I really would like to thank you for your time, and I will turn this over to our esteemed moderator. Thank you so much.
Thank you, Dr. Mann. Thank you for your opening remarks. In the midst of the COVID-19 pandemic, Latinos and other diverse communities are also suffering from another threat to their lives, cardiovascular disease, or CVD. Despite extreme advancements in medicine and public health, CVD remains the leading cause of death in the US and worldwide. Cardiovascular diseases can refer to a number of conditions such as heart disease and stroke, the two leading causes of death in the United States. Let's welcome our first speaker, Ruth Hoffman, Executive Director of Policy Strategy and Industry Trends for Amgen. At Amgen, Ms. Hoffman provides thought leadership on emerging trends and manages policy engagements with industry trades and think tanks. She has been with Amgen since 2007, having previously served as Director and Senior Manager for Federal Affairs. She has served previously as Director and Senior Manager of Federal Government Affairs, respectively. Today, Ms. Hoffman will highlight the impact high cholesterol is having among diverse populations. So please help me welcome Ms. Ruth Hoffman.
Thank you. It's a real pleasure to be here and share, our insights on cardiovascular disease at this health equity discussion. Like you said, cardiovascular disease is, a leading public health issue in the United States. There's heart attacks and strokes and other events. If you could advance to the next slide. And there's significant health challenges surrounding cardiovascular disease, both on the quality of life and also on the cost to the system and the economic burden that it imposes on patients suffering from this disease. There's 100 million Americans living with cardiovascular disease in the United States. Every 40 seconds, someone has a heart attack. And there's 800,000 deaths every year. All of this leads to what they project to be about 1.1 trillion cost to the system by 2035. Now, in between 1970 and around about 2010, there was significant progress on treating cardiovascular disease. It expanded the life expectancy by about 7.8 years. And a lot of researchers and public health officials really credit, better awareness around better exercise and eating a more healthy diet and decreasing smoking. But there was also a lot of innovation that brought statins to the treatment of this disease. And so there was significant progress up until about 2010. Then researchers and public health officials noticed that it started to plateau, and actually those trend lines started to reverse. And this was at a time when there was even greater science and greater innovation in treatments to treat this disease. So it really caught a lot of public health officials' attention, and they really started to pour a lot of resources and time and effort into creating more awareness around this cardiovascular disease. Health and Human Services put a lot of resources and stood up partnerships between CDC and the Centers for Medicare and Medicaid Services to really drive awareness. There was the Million Hearts campaign. Healthy People 2030 really created a lot of awareness about the trend lines. There were initiatives called like Wise Woman to really help, draw attention to how important it was to know have your blood pressure tested, know what your cholesterol levels were, and better exercise and eating more healthy foods. Next slide, please. So in the last few years, there have been, improved disease outcomes, a large part from that better awareness, but there's still a striking disparities among racial and ethnic groups. We know that racial minorities, especially Black Americans and Latinos, have higher rates of cardiovascular disease and tend to develop this condition at an earlier age than non-Hispanic white populations. We also know that there's multi-dimensional disparities in social determinants of health that really play, a role in this. And, it creates challenges to achieving, better cardiovascular health outcomes. And I think we all are aware that COVID really shined a light on, disparities and how minorities were disproportionately affected by COVID, and also underlying disease and comorbidities that really, impacted how patients handled COVID. Next slide, please. Now, this is kind of a busy slide, but researchers took the 2020 US Census data and overlaid population health data and forecasted what the next 4 decades would look like. They took the trend lines from diabetes, high cholesterol, and obesity, and found that they expected about a 40% increase in diabetes by 2060. High cholesterol is expected to increase 30%, and obesity increase 18%. And so this slide reflects what kind of impact that will have on cardiovascular disease, as those are the diabetes, cholesterol, and obesity are drivers, the underlying drivers of cardiovascular disease. So the gray part of the slide, it represents how many Americans are expected to have ischemic heart disease in 2025. And then the yellow represents the increase and where that population will be at 2060. So for example, ischemic heart disease. In 2025, they expect 22 million to have ischemic heart disease. And then by 2060, that'll be a 31% increase, which will represent 28.7 million. On myocardial infarction, which is a heart attack, that 12 million are expected to have, in 2025, a 30% increase, which will bring us to 16 million in 2060. And stroke is 11 million for 2025, with a 34% increase, reaching 14.5 million by 2060. And I think what is most concerning that we want to shine a light on is that the researchers are finding that white individuals, that the risk factors, the underlying risk factors and the disease is projected to decline. But at the same time, there'll be significant increase in both the driving factors, in obesity, cholesterol, and diabetes in minority populations, which will create worse outcomes for Black Americans and Latinos. This data was published in the Journal of American College of Cardiology in August of 2022. Next slide, please. Over the last 6 months, Amgen wanted to get a better understanding of what type of treatment. We know that, like I said earlier, someone has a heart attack every 40 seconds. We also know that 1 out of 5 will have a second event within the following 12 months. So we wanted to look at the data to see in the Medicare population, what was happening, how many patients were being measured for the LDL 90 days post having a heart attack. And we found that it was woefully under, an acceptable low rate, that we expect it to be at 80, it should be at 100% measuring within the first 3 months. According to clinical guidelines, it should be measured within the first 4 to 12 weeks. But we found that overall about 30% are measured within those first 3 months of being discharged from a hospital after having a heart attack. And as you can see, Black Americans are at 26% and Hispanics are at 33%. And then moving to the right-hand side, we see that there's great disparities in minority populations. So this number is compared to whites. Whites would be at 100%. So you can see non-Hispanic Blacks are on, likely to be on statins at only 65%, and Latinos only at 68%. So now we have a new Congress coming in January. We know that there needs to be better education on, the trend lines, the poor follow-up care following a heart attack. We need to continue to shine a light on the disparities. I think what we learned, lessons learned from COVID, did help to get, policymakers' attention. And I believe the Biden administration and many members in Congress want to close that health equity gap. But I mean, it's upon all of us to continue to advocate for, better care, better treatment, and better access to treatments to address cardiovascular disease. This is my last slide, and happy to stay around for questions. Thank you.
Well, thank you so much, Ruth. We know that you are not going to be able to stay for the whole time, so if you wanted to answer the questions now, I can do that. Okay, so we did have a question for you, and it is, what are the mechanisms driving the decreases in cardiovascular disease in white communities? And does this descriptor also include white Hispanics?
That's a very good question. I think what we found is like there is no one barrier and no one solution to this problem. I think it's a combination of, level of coverage, if coverage is available, or if someone is uninsured, the healthcare system that's available to patients, transportation to those systems, protocols that those systems adopt, and how quickly they're able to follow any changes in clinical guidelines. And so I think there's policymakers that are trying to answer that equity gap between different communities, and to try to close those gaps through policy, whether it's coverage, level of coverage, out-of-pocket costs, transportation barriers, structural bias in the system, and make a difference, because they do know, looking at the trend lines, that there's too many people suffering from cardiovascular disease.
Indeed. Well, thank you so much for your time today. If you can stick around a little longer, we greatly appreciate it, but we understand if you have to go. Thank you so much for the excellent presentation. Now we're going to move on to our next speaker. But before we do, I just want to mention to anyone who's listening today that if you have any questions for our presenters, to please type them in the chat box, and we will make sure to address as many of the questions as possible during a Q&A session. Okay, so now let's switch a little bit our gears, and let's talk a little bit about vaccines. It's a fact that everyone needs vaccines throughout their lives. The CDC recommends that adults keep their vaccinations up to date because immunity from childhood vaccines can wear off over time. You are also at risk for different diseases as an adult. Vaccination is one of the most convenient and safest preventative care measures available. It's important to highlight that vaccines are recommended for adults based on age, health conditions, job, and other factors. But let's hear more from our next speaker, Dr. Henry Pacheco, a family physician and the National Hispanic Council on Aging's medical advisor, who is joining us via phone today. We welcome Dr. Pacheco.
Hi, how are you? Can you hear me?
Yes, we can hear you. Thank you.
Great. I'm on the phone here. Yes, I'm going to discuss adult immunizations, and I thank you so much for inviting me to this discussion of all these very important conditions. Let me get this going here. Okay. Yeah. Well, we need to understand the importance of vaccinations. If you look at the world before vaccines, for example, it was a horrible world. Smallpox, for example, killed at least 500 million people in a span of about 100 years. Smallpox is a horrible disease. It disfigures. It doesn't kill you. It disfigures, and it causes a lot of suffering, a lot of death. Measles, for example, there were about 2.6 million deaths every year during an outbreak. And outbreaks occurred almost every 2 to 3 years. Same thing, horrible disease. Hepatitis B, 780,000 per year died of hepatitis B complications. And let's keep in mind that many of these are viral diseases for which there's really no effective medication or cure. Polio caused something like 50,000 cases of paralysis every year in the 1950s. We look at measles, not only it cause the severe fever and death and this and that, but it also a lot of the children that or even adults that suffer and survive measles ended up with mental retardation and central nervous system damage. This is a very contagious disease. Case of measles, for example, if you walk into a room where there was a person with measles, even up to 2 hours later, you can still catch it. So it's a very contagious disease. Likewise, rubella outbreak, resulted in something like 20,000 children affected with brain damage in the 1960s. And of course, the flu pandemic, the so-called Spanish flu pandemic of 2018, caused over 20 million deaths worldwide. So we are dealing with something that with horrible diseases. And of course, in desperation, we sought better ways of handling this, and of course, we had no protection. And of course, prior to the advent of vaccine, millions of people became severely disabled and died from these viral and bacterial infections. Vaccines have really saved millions of lives over the years, which we have to recognize what a miraculous strategy this has been. Yeah, and vaccines are one of the best defenses against many serious infectious diseases with high mortality and morbidity. And of course, in many cases, vaccines protect us for life, and in some cases, we need to have them repeated every year, like the flu vaccine, or every 10 years, like tetanus. So it's been a miraculous fight of human beings to protect themselves against these horrible diseases. Essentially, how everybody probably knows how vaccines work, but essentially a vaccine contains either live, attenuated, or killed virus or bacteria, or like in the case of COVID, pieces of the microorganism, the virus. And these, when injected in the body of a healthy person, it provokes the immune system to put up a fight, to put up antibodies against this specific organism, and that's how it gives us the protection. So that when a person becomes in contact with the disease, it already has the protection to fight it effectively. Vaccines is as I mentioned, is one of the greatest accomplishments in public health. It's indeed miraculous that we have this in our armamentarium against diseases. So essentially, what is the problem? Somebody, I copied this from some source, and unfortunately I forgot the source, but the source mentioned that there's a catch-22 to vaccines, and that is that vaccines save us from diseases. And then it causes us to forget the diseases from which they saved us. We just don't think about those things anymore. We don't think about polio. We don't think about smallpox. It's just out of our minds. And once the threat appears to be gone from our lives, we become lax. Or worse, we make up other things to worry about. So essentially, we become complacent. We just don't even worry about the disease. And in many cases, this thing about not worrying the disease makes us not even think about the vaccine itself. So there is a catch-22 to that. And of course, now in the past decade or so, we run the risk of becoming overwhelmed or swayed by incredible penetration of anti-vaccination messages. I mean, there always has been an anti-vax movement, but you could hear them locally in meetings and maybe on television news, maybe especially. But now it's on social media and it's everywhere, and you get bombarded by this very misleading messages. But they have a certain attractiveness to people because it raises our suspicion about the government, about scientists, about this. And makes people say, well, let me think about this for a minute. Let me just wait, So we have a tremendous uphill battle against these anti-vaccination messages, so that are so widespread, and they're widespread not just in media, but from individual to individuals, word of mouth, a lot of that. So despite the tremendous benefit of vaccines, 3 out of 4 adults are missing one or more routinely recommended vaccines. 3 out of every 4 are missing this incredible protection that we've gained over the years. We have a collection of conditions for which we are, we have vaccines, but let me just focus on the flu, which is very current. This is about the time that we should be getting our flu vaccine. Essentially, who has the lowest vaccinations of flu? Well, adults age 18 to 44, it's predictable. These folks think that they are, strong, healthy, and invincible. Mostly males. These are the ones that have lower flu vaccination rates. Mostly males, mostly African American or Hispanic. Those folks also have less than a high school diploma, so they're not well educated, they're not well informed, and they may not be grasping the reality of what really surrounds them. And of course, they have an annual income less than $50,000. So they have, folks who have to struggle for life, have to work hard, and they have poverty as something they have to deal against. And of course, one of the biggest things is that they have no health insurance. Although, when you think about it, the cost of vaccines out of pocket for someone that doesn't have insurance can be $50 or more if the doctors say, well, you have to have an office visit to get your vaccine. But in any case, even those nominal costs in many places where there is still, if you're insured, you're pretty well covered. Medicare, Medicaid, and all those, you're well covered. If you're not insured, that's where the problem is. But even those costs, are minimal compared to the costs of being hospitalized with the flu or staying at home and losing your job, your income. You may not lose your job, but you lose your daily income, and the possibility you can pass the flu to other family members, perhaps even older and weaker, and that might cause severe hardship, including possibility of death. So even then, the cost, even if you have to pay out of pocket, is more than worth it. So yes, these are the folks that have the lowest vaccination rates. Flu vaccine coverage for whites is about 54%, about 42% for African Americans, and also for Hispanics, American Indians, I think it's 41%, and Hispanics about 38%. Same thing. These things reflect, the hardship that these folks have to face in keeping up with their healthy health routines, because they're struggling against many things that are socioeconomic burdens. And also we have to keep in mind that people from racial and ethnic minorities are also more likely to be hospitalized with the flu. 80% higher for African American adults, 30% for Native American and Latin Native, and 20% for Latinos. And being hospitalized with the flu, other than the incredible risk and the pain and the suffering and the risk that if you're hospitalized, you're in bad health. So essentially, I have 3 minutes. So essentially, it shows you that there's a lot of work that we need to do. More recently, the world has been turned upside down. In December 19th, there was an outbreak of respiratory disease in China, December 2019. By January, we had the first confirmed cases in the U.S. And then by February 2020, the first deaths reported of a disease. And now we call it COVID. And, by March 13th, we're in a nationwide emergency. It has moved so fast over a period of few months. And, then COVID vaccine comes out in December. That was very quickly. But, let's keep in mind that scientists have been working on this vaccine for many years for this family of viruses. So it's not, it's not that they just started. And then, but here's the thing, by December 2020, in 1 year, we had 350,000 deaths of COVID. And by May 2022, there were over 1 million deaths in the United States of COVID. It's very frightful. Compare that HIV, for example, in over 41 years since the epidemic in 1981, we've had 700,000 deaths. So COVID, if you put it in that perspective, is very frightening, of course. This was an incredible surprise that woke us up in the past 2 years. Vaccine rates in 2021 were very low for obviously for African American, Hispanic 22%, Hispanic 29%, whites 33%. However, we've gotten a lot better by the end of 2021, let's say by November or so. Rates of vaccination among African Americans has jumped up to 78%, Hispanics about 81%, and whites about 78%. It's encouraging, and we have to say that practically all the deaths of COVID are now among unvaccinated people. More recently, the newest threat is monkey virus. It has, boom, all of a sudden appeared. May 2022, they reported first cases. Very large pimple-like pustules. Monkeypox is scary because it reminds us of smallpox, a horrible disfiguring disease. But monkeypox is nowhere near as severe. Nevertheless, it has caused, there are 26,000 cases in, I think, by October 22, and 6 deaths already. And so, it's a disease that affects mainly men that have sex with men. Of course, once again, minority, African American, Hispanic have higher rates, slightly higher. I think whites are also around, they're all around the 30%. And of course, this is particularly affecting folks that have sex with men. Now, there is under the Emergency Use Administration, there is a vaccine that is being used to counter monkeypox. It's called the Jynneos vaccine. I never know how to pronounce it. It's two intradermal shots, let's say. So, but then again, this once again raises how fragile our condition is to these diseases. Christine, give me an idea how much time I have left. Okay, wrap it up, she says. All right. Well, this is what we're faced with in immunizations. We're not taking full advantage of what we have to counter. We still have very low immunization rates. Where are people getting most of their vaccines? Most of the vaccines people are getting it in doctor's office, and of course that's a problem where people are uninsured. But there's a slightly increasing number of people who are getting their vaccine at store fronts like CVS, Walgreens, and many other places, and shopping malls where they offer this. So there is some hope that it's going to become more generalized and outside of the doctor's office. There are, of course, a few other vaccines that adults need to worry about, such as the tetanus vaccine, obviously the Haemophilus influenza vaccine, the pneumococcal vaccine. These are vaccines that your healthcare providers should alert you. So essentially, adults should have access to their records at all times and make sure that they're updated, and make sure that their clinicians are aware of it. But more than anything, physicians and healthcare providers have their work cut out for them because of the low vaccination rates. Hospitals, physicians' offices have the electronic medical records and other mechanisms for making sure that every patient is vaccinated, but this has not been used to the maximum yet. There's still a lot of room that needs to be covered. But what about those that don't have access to healthcare, those that don't make it to doctor's offices? Well, the family and community is where this needs to be amplified, the message of vaccination. The family, community-based organizations are resources that we need to empower and access to promote vaccination, not just by getting individuals vaccinated, but by urging them to become involved in promoting vaccination. So there should be a movement inside the communities, inside families, to talk about the need to be vaccinated and to counteract the misinformation circulating in social media. So the bottom line is that we only have about 25% of adults that are up to date with recommended vaccines. So we have a lot of work to do, there's no doubt. This is more or less the message, that we still have a lot of work to do in adult immunizations, but I just want to thank you for allowing me to give this brief message. Thank you so much.
Well, thank you, Dr. Pacheco, for such an informational, educational presentation today. Thank you. And if you can please stick around for the Q&A session a little bit later. Now let's continue on. Sure. Let's continue on with our next topic. Equitable representation of Latinos in health research is needed to achieve health equity in different areas, like in research for cancer, diabetes, and other diseases. However, many groups, especially communities of color, have been historically underrepresented in health research. And what happens if communities of color are not included in health research? Well, this is the issue of great concern because health research determines how treatments like medicines, vaccines, or medical devices are used. If the participants in health research do not accurately reflect the diversity of the population, it's difficult to know how different people will react to the treatments or how effective they will be. So let's hear more about this topic from our next speaker, Ms. Christine Perez. She's the Director of Programs at the National Hispanic Council on Aging, a national organization that works to improve the lives of Hispanic older adults, their families, and caregivers. Ms. Perez has over 5 years of experience as a program specialist in effectively implementing and managing social and public health programs that are used to boost fundraising, increase partner membership, and enlist support from government agencies and corporations with the mission to support older adults, their families, and their caregivers. Ms. Perez is passionate about working to reduce health disparities and increase participation among the Hispanic community in health research. Today, Ms. Perez will provide an overview about Latinos and health research, the challenges, and the opportunities. Please help me welcome Ms. Christine Perez.
Thank you, Teresa. Can you hear me?
Yes, we can hear you.
Thank you. Good afternoon, buenas tardes, and thank you, Teresa, for the kind introduction. So today I want to provide an overview about Latinos in health research, some challenges and opportunities. So the next slide, please. So while Hispanics are one of the fastest growing population in the United States, and yet they're underrepresented in health research. So for example, while people of Hispanic backgrounds comprise approximately 18% of the US population, well, less than 8% of them participated in health research studies. So I want to emphasize that participation in health research promotes medical equity. And this is because research participants are key to making medical progress, and so is the diversity among those participants. And therefore, to advance equity in healthcare, we believe it's critical that all people, including people of color, should participate in health research or clinical research studies. So this is important because of race, disability, and the socioeconomic status and other demographic factors that can affect people's risk of developing certain conditions. And it also can impact their responses to medical interventions and their overall health outcomes. So again, the more the participants who take part in clinical research make up a diverse group, the more likely that the research results will apply to a diverse group of patients. So again, it's important that the research participants represent the people who are most impacted by the disease or certain conditions that are being studied. For example, certain disease like cancer, sickle cell diseases are more common among people of color. So again, it's crucial that people of color, right, take part in clinical studies of the serious illnesses. So in this particular slide, I want to talk a little bit more about the Latino community that has faced a lot of barriers, right? A lot of barriers that have limited their participation in health research. So today I will highlight some of them that researchers may encounter when reaching out to Latinos. So the first one of many that we have, right, is the language barrier. So here, communities in our country speak numerous different languages, right? And many older adults in these communities have limited English proficiency. However, invitations to participate in health research here in the United States are generally offered in English. And important information about how to enroll in this type of research opportunities and knowing the risk and the benefits of doing so may not be successfully communicated to diverse communities due to the language. And we also have the fear and mistrust. A lot of information about medical research can be hard to understand, and many people might not know about the benefits of health research. And people interested in health research might be afraid that their information will be shared and used in ways that they do not agree to. And also they may encounter the fear of the side effects, also the fear of being experimented on when joining health research study. And we have the previous experiences with health-related issues. And by this, I mean many communities, including Latinos and people of color, have had to deal with discrimination, marginalization, and even trauma in their experience with medical care, and that limits them to participate in health research studies. So in the next slide, we also want to highlight some tips for researchers wanting to do research with Latinos. So it's important for them to consider the following, but not limited to, the importance of translating all outreach materials into Spanish to recruit participants, also in a cultural and linguistically appropriate manner. It is important to have an interpreter who can interpret for research participants. This can facilitate the process of retaining participants into the health research study. And again, it's important to partner with trusted nonprofit organizations to engage and do outreach as part of the recruitment process. Believe me, the nonprofit organizations, they know their people, they have the trust and can help with enrollment. And it's always important to invest in outreach and allocating funds so that the study can recruit the necessary number of participants. For example, participating in health fairs, joining cultural events in your area, going to community centers, doing radio announcements, and many other things that you can do. So when Hispanics, and then in the next slide, when Hispanics participate in health research, there's an opportunity to be better represented in decision-making and medical advances. So again, I want to emphasize that if we want a better quality of life, better treatments, and disease prevention for ourselves, our families, and the community that we live, it's important to participate in health research. So I have a question for all of you, is that if you're curious about any health research programs that you could actually participate in, well, in the next slide, I want to provide a brief overview about the All of Us research program. So for those who are unaware of the program, I want to provide an overview about what it is. So the All of Us research program is led by the National Institute of Health, or also known as NIH. And the program is working to gather health information from 1 million or more people from all across the United States. And this is to help researchers learn more about how genetics, environment, and lifestyles affect health through inclusive and also diverse strategies that can accommodate participants, their culture, and their traditions. So again, our differences enrich this program, and it works to provide researchers with data that reflects the diversity of the country. So the program is open to people both healthy and sick, and from all communities. Unlike a single research study that is focused on specific disease or population, well, the All of Us research program will serve as a national research resource to inform thousands of studies covering a wide variety of health conditions. So again, contributing to the All of Us research program makes it possible for your community to be represented in medical research. So in the next slide, I want to present some core values that are central to the program and the foundation on which the program is built, right? So for example, participation is open to all people living in the United States. It's free, and the program will not ask you for your social security number or your citizenship status. Sorry for that. So also participants are viewed as partners in the program, so they have benefits when joining. So the participants from the program will be able to view their health information and learn more about their health. So this information can be very helpful when making important decisions with your health, with your health and with your healthcare providers, for instance. And all the information shared in the program is protected. Identifiable information such as your name is removed from the data and replaced with a code. And the information is stored in a database with strict privacy and security measures, because we know that we are very interested in the privacy, right? Not our information to be shared with other entities. So in the next slide, I know you may have some questions. So what is the process for as a participant, right? So, well, this is an opportunity for you to learn a little bit more of your own health indicators and get your own data. It's also an opportunity to ensure that your community is included in the studies that may lead to new understanding and new treatments. So the opportunity, again, to be part of is an opportunity for everyone, right? To be part of this movement to make our healthcare more precise, more personal, and also more effective. So this is an opportunity to help create more representative medical research. And in the next slide, I know I mentioned about participants, so I want to highlight that this program also invites researchers. And the promise for the researchers is the opportunity to save time and resources and accelerate research breakthroughs by leveraging. I'm going to highlight some of them. For example, you will be able to have access to a rich resource of data, including by specimens and increasingly robust electronic health records. And you'll be able to have a longitudinal data set that will follow participants as they move, age, develop relationships, get sick, and try treatments. And also, you will have a diverse cohort of participants, including people that are healthy and sick from all parts of the country. And also, you have access to both raw and raw data and data that it's already clean and curated, among many others. So in the next slide, you might be thinking, so, okay, I'm interested, what's next? So how can you join the All of Us research program? Well, here are the current protocols for participants. The first one is, of course, you need to enroll via, if you have access to a computer or smartphone, you can access www.joinallofus.org/together. And this information I will share later. Provide consent and authorization to share your electronic health data, and consent to get DNA results. And the second, you need to answer some health surveys, and later on you will be asked to provide physical measurements, and later provide some biosamples. And at the end, if there's an opportunity, you will get access to wear some digital apps and other wearable tools. And the next slide is, so why now? Wow. We have the technology that can collect huge amounts of data, and more people are engaged in their health. That's the truth. And we have a greater understanding of human genes. So again, I want to reemphasize that the importance of being part of this initiative is that over time, the participation of Latino and Hispanics in this research will be crucial for medical advancements and even treatments of different diseases and conditions in our community, such as diabetes, high cholesterol, among many others. So this will help to provide more precise treatments that can ensure a better quality of life for future generations. So in the next slide, if you're interested in joining the All of Us research program, before ending, I want to have this, question for you. If you want to be part of history and play a role in increasing Hispanic and Latino representation in health research, well, now is your time. If you have a smartphone, you can scan the QR code that appears in this slide for more information and scan it. And you can join this program for free, as I mentioned before, and via your smartphone or website. So in the next slide, I have more information in case you want to read more or have access to more information about the program. Well, you can join again via www.joinallofus.org/together for English information, and also the same www.joinallofus.org/todos juntos in Spanish version. And again, remember, it's in your hands to shape the future of your health. So the next slide, I think I ended. And for more information, please feel free to follow us in our social media platforms or send us an email or call us. So thank you so much for the opportunity. Back to you, Jarissa.
Well, thank you so much, Ms. Perez, for your contributions to this discussion, all that great information overview about participating in health research, which is so important, and that great overview of the All of Us research program. Now, I just want to, before we move on to our next topic, want to remind all of our attendees, if you have any questions for our presenters, please type them up in the chat box, and we will address as many of your questions as possible during our question and answer session. Now, this next topic is one that's very close to me. I just want to thank NHCOA for the opportunity to talk about Alzheimer's disease. You know, this is a disease that impacts the Hispanic Latino community in particular. According to the CDC, the rates of Alzheimer's are projected to triple by 2060. And while everyone is at risk to develop this devastating condition as they age, Hispanic Latinos are predicted to have the largest increase in Alzheimer's and dementia rates. According to the Alzheimer's Association, the Hispanic and Latino community, we are 1.5 times more likely than whites to have dementia. And we are more likely to have other risk factors for Alzheimer's, which include low socioeconomic status, cardiovascular disease, obesity, diabetes, and other factors. So it is my honor and pleasure to welcome our next speaker, who's become a great friend over the last couple of years we worked together, my co-PI, Dr. Adriana Perez. She's an associate professor at the University of Pennsylvania School of Nursing. She has served in various leadership roles locally and nationally to advance health equity among Hispanic Latinos and other historically marginalized communities. Dr. Perez has served as policy advisor of the National Association of Hispanic Nurses, Public Policy Committee, and the Gerontological Society of America, excuse me. She was selected as a Congressional Health and Aging Policy Fellow, supported by the Atlantic Philanthropies and Centers for Disease Control and Prevention Healthy Aging Program to work with Latino city planners, local policymakers, stakeholders, and residents to inform environmental policies that promote healthy aging. Today, Dr. Perez will provide an overview of Alzheimer's in Latinos, an update on the status. Please help me welcome my good friend, Dr. Adriana Perez.
Gracias, Yarisa. Gracias, amiga, and all of you. It's great to be in this space again with the National Hispanic Council on Aging and so many colleagues that are focused on something that I'm very passionate about as well, and that's promoting the health and wellness in our older Latino community, older Hispanic community. It's what I'm dedicating my career to, my clinical and my research career to, because I feel like it is a community that is often not just underserved, but excluded, not invited to the table. And I'm joining you today from Juniata Older Adult Senior Center, actually here in North Philadelphia, where I have a study that's focused on Spanish-speaking elders and addressing risk factors to Alzheimer's disease through physical activity, through building social support, through building community networks and resources, and ensuring that they are part of the design of programs that help to prevent and help address risk factors related to Alzheimer's disease. So I'm very excited to share some of this work, as well as work that has been in partnership with organizations like the Alzheimer's Association, my colleague Yarisa, and other leaders there, as well as the National Association of Hispanic Nurses and others. So thank you for having me. Next slide. And you've heard, Yarisa, thank you. You heard some of the statistics from Yarisa, some of the data, right? Approximately 13% of Hispanics, Latinos who are 65 and older will have Alzheimer's or some other form of dementia. Yet we remain understudied, despite the fact that we are 1.5 times more likely than whites to have dementia. We remain an understudied group. And thank you so much, Christine, for talking about research. I will talk about it a little bit more because it is an area that we really need to focus on and ensure that we're supporting and including Latinos and other historically marginalized communities into clinical trials. And we need to make the research infrastructure more inclusive and more accessible to communities that are, again, marginalized. Because we're a young population and we're growing in size, that means that we're growing in size in terms of the older adult population. We are expected to, by the year 2060, experience an increase of about 800% when it comes to Alzheimer's disease. Every time I start an education seminar for the community, I always start with these facts, because it's very rare that people know these statistics. And so when they hear this, they're very interested. And it is alarming to hear that this is the kind of risk that we're up against. And there are many factors that contribute to this. The field of studying Alzheimer's disease is broad, and people are studying the environment, both the physical and social environment, as well as other risk factors, lifestyle, community, various different factors that put a person at risk for Alzheimer's disease. And so throughout the presentation, I will cite work from the Alzheimer's Association, some surveys that they've done just recently, as well as a recent Alzheimer's and dementia health disparities report that was published last year. Next slide. Here, this is a great visual of the map showing Alzheimer's disease and related dementias by county level, looking at people of color that have Medicare. So the darker the areas, that's where you see the highest incidence of ADRD in people of color and where we are. So by looking at this, there is no doubt that there is an aspect of the environment where people live and the incidence of Alzheimer's disease. I moved from Arizona to Philadelphia 7 years ago, and one of the first studies that I did is, in addition to conducting community-based research, was look at the environment and look at the zip code where most older Latinos live. And it wasn't a surprise to see that there were other environmental issues that also put a person at risk for Alzheimer's disease, and things like high levels of crime, fear for safety, that result in a fear of safety, the noise level, the poverty level, all of these things that contribute, that we know contribute and perpetuate a system of inequity that put us at risk for Alzheimer's disease. Next slide. So here are some of the contributing factors, and there are many. You know, this could be several slides, but I followed instructions. I was told only 11 slides. So I thought, okay, let me highlight the ones that I feel like really need our attention, and ones that I want to make sure we could leave with, you know, here are factors, but what are things that we can do? Well, first of all, as I said, you know, we're getting older as a population. We tend to be a younger population, but we're growing old. And that's a good thing. You know, the fact that you get to be a certain age is a real privilege here in the country. And aging is the greatest risk factor for Alzheimer's disease. As well as you've heard about some of the inequities that we already experience as a population, many related to vascular disease, issues of the heart, high blood pressure, as well as diabetes, things like depression. We experience these disparities at a higher rate than other populations. So these all lead to, you know, Alzheimer's disease. They contribute to that risk factor for Alzheimer's disease. But I'm very excited too to look at other issues that also contribute, you know, social determinants of health, including the social environment, economic environment, and where we live, where we not only where we live, but where we work, play, pray. You know, as we age, from a very from the time we're young to the time, you know, that we age, what is our environment like, and the experiences that we have in this country. And again, I think you've heard a little bit about other issues like the system. And in the system, I include the research system, the way in which research is conducted in this country that really not only are not inviting to people that don't speak English, but also make someone can be intimidating to a person, especially when the researchers do not look like them, do not understand them, do not understand their language and their culture. That puts us at a disadvantage. As I mentioned, you know, the survey and study that the Alzheimer's Association conducted last year showed among Latinos, this is what they reported. These were barriers to getting excellent health care and support for Alzheimer's. Affordability, you know, like I said, all these issues related to economic barriers, the lack of good health care. Yes, having insurance, but do you have a place and a medical home or a health home where people understand you, where you feel like you're being heard and you're being understood? Those are very important. The lack of family and social support to help. Most Latinos, even though, you know, the population is aging, we have young adults taking care of older parents, grandparents, and younger people. So there is, you know, anytime that colleagues, you know, we plan on conducting research and they talk about caregiving and they say, well, what about their family, their kids? And I always say, you know, they're not with them. They are working. They have, you know, they have multiple other things. And so that's part of the challenge, is looking at how caregiving and providing care looks in our community. It's not often one person, but it's a shared responsibility among many. And you know, changing the way in which we look at that is important, because not all families don't look the same, and we need to take that into account. Is who serves, who is the team that's providing care to the person experiencing, you know, memory problems. Next slide. So this is what I want to focus on a little bit more, because you heard about the exclusion of Latinos and other marginalized communities into research trials. Here is an example of something. Last year, the US FDA approved for the first time a medication specific for Alzheimer's disease. These are the medications that are published every year from the FDA. These are the ones that are for neurological and psychiatric disorders. The one that you see at the very top is one for Alzheimer's specifically. Approximately 3,300 patients were enrolled in these two large clinical trials across 19 countries. 46% were people from the United States, 52% were female, 78% were white, Asian 9%, Hispanic Latino 3%. Black participants were 1%, and 12 did not report a race. So when you hear that we are 1.5 times more likely to have Alzheimer's disease, develop Alzheimer's disease or related dementias, but yet we are only 3% of those included in clinical trials. This only perpetuates disparities because that means that treatments do not include us as a community and how a treatment might be different or how that treatment functions in people of color. So I'm with many of my colleagues in the field who say this is not acceptable. This cannot stand. We need to make sure that research is inclusive, especially of the people that are suffering disproportionately. So my goal now is to change this and to ensure that we are not only included in clinical trials, but we're part of the design of clinical trials to say, you know, yes, it works this way, it's worked this way, but you have to consider, you know, people's transportation to get to a study, the involvement of other people. Most clinical trials, you know, expect that you will have the same caregiver for years when you participate, and that's a hard commitment. And also, you know, we experience these symptoms at a younger age. Most clinical trials want people at 65. And so I've, you know, talked to colleagues about looking at that age because in practice, I see patients that are much younger and already experiencing symptoms of mild memory impairment. So we need to look at the differences, at the variation, not just from, you know, populations, but even subpopulations. The study that I have now is very culturally diverse with predominantly Puerto Rican, people from the Dominican Republic, Colombia, and there are cultural and linguistic nuances that are important. And people come to this country from different countries where education systems are different. And most of our memory screenings say, you know, if you have up to a 12th grade education, this is how you score. When some countries, that's not the way the education system is made. So a lot to think about. Next slide. And to me, this is also another big issue. There's lack of representation in the healthcare workforce. I've been a nurse for more than 20 years, a member of the National Association of Hispanic Nurses. And one of the most disheartening, you know, data points that I, you know, share with people is I've been a nurse for 20 years, and the growth of Hispanic Latina nurses that are bilingual, bicultural, and can have an immediate effect on a person's experience when they're sick, it continues to be dismal. We're not keeping up with the growth of the population. When I graduated, it was less than 5% of nurses in this country, almost 4 million registered nurses, less than 5% being Hispanic Latino. It has not changed that much. You know, here you see for Hispanic workers overall 8.4%, and in nursing it's still about 5%, has not changed. And as you go, you know, starting here with EMTs, nurses aides, this is where you'll find the higher numbers, 17%, 12%. But as you go up the chain of care and who is at the top making decisions, physicians, primary care providers, neuroscientists, those numbers drop. So we don't have the representation at the very top level where we need the representation and people to understand the patients. So this is another issue that without changing this, I'm afraid that we're going to continue to see the disparities in the community, not just to Alzheimer's, but to many, many other chronic conditions. Next slide. And so in this same survey, I cannot underestimate how important people say that they have to have someone that is not only linguistically responsive, but also culturally responsive. So I ask you to think of yourself, being in a different country, many come here, immigrate here for their family, to escape, violence in their country, and then experience so many challenges being here. So having a provider who understands your language and your culture, not just the challenges of the culture, but the strengths of your culture, that's necessary in order to promote health in a person. So across the board, people say this is important. Yet when you look at the blue bar, purple is how important it is. The blue is how confident am I that that actually exists. So it's not matching, with what they would like. Next slide. There is good news. I think there's a lot of great work. You know, I love hearing colleagues today talk about the work that they're doing. It reminds me that, you know, we're not alone in this. We're a growing community of advocates, of leaders, primary care providers, families that are really promoting a better way for the community. For me, one of the most positive signs is that Hispanics and Latinos want to take part in research. I hear it all the time, and the Alzheimer's Association survey showed that. It ensured that we have the data to say people, when they understand and when they know about the research, 85% said they would volunteer if they are invited. So when they see things like must speak English proficiently, they understand that to mean you're not invited. They might be bilingual, but that's the message that they are understanding. 83% want to contribute to the goal of research. They see it as a legacy that they would leave behind for their family. Maybe I won't, you know, benefit, they say, maybe I will be gone, you know, 5 years from now, they're older, but my children, my grandchildren will benefit. And 74% say they want to do it because they themselves have a family member with the disease. There are many national efforts. I do want to point out and you know, acknowledge that at the federal level, there are policy, I mean, Yarisa, you know, could talk about our policy work and current legislation now that we're supporting to ensure that we continue to move the needle forward and make research accessible. So I think, to me, this is good news. We are changing the landscape. Next slide. I think the first thing is just promoting awareness. I still find so many people, you know, that do not know about their risk factors. 6 out of 10 believe that memory loss is a normal part of aging. And so when they learn that it's not, it's just like this light goes off and they want to do something about it. So promoting this in a very culturally responsive way, yes, in Spanish, but also in a way that gets at the value of the person, what they value and what they see as important for them, their community, their family. Next slide. Just some other things too that I feel like in terms of the state of Alzheimer's disease in our population, there are millions and millions of dollars that have been poured into studying drug trials. And again, they don't include Hispanic, Latinos, and other marginalized communities. I think that it's important to focus on drug trials and treatment, but there's a lot to be said and a lot more that we can do to promote health in the community, to focus on prevention, to focus on supporting a healthy lifestyle through blood pressure control, through an environment that not only supports physical activity and access to healthy food, but that actually becomes the default, that anywhere a person goes, they feel safe walking and they can buy affordable, healthy food. And we have to really think about this and research, especially using a strength-based approach, not a scare tactic or, sort of making people feel like they should do it out of the kindness of their heart. Yes, most people do want to do it because they want to do something, but we need to ensure that we're compensating community partners that are part of the research, as well as people themselves, you know, the time they take off work, their need for transportation, whatever the case may be. I think that we need to address needs and also focus on their strengths. The role of social support, there's decades and decades of research that show this is important for the community and must be included. So our messaging needs to change. And, you know, I know that for many people, the take care of yourself, self-care, yes, that's important, but that doesn't always resonate with a community and a population that thinks of others first, that thinks of their family and their community first. How do we leverage that messaging so that we are consistent with what's valuable to that community? So, you know, they will never do it for themselves. And so we need to stop saying that, you know, it's okay for people to think of others. I feel like we could use more kindness now in the world and people to think of others. So I actually, you know, build that up and really acknowledge that people think of others first, and providing people with the knowledge, the resources, the community connections to be able to, first of all, learn more about Alzheimer's disease and the risk. Very proud of the work that we've done with the Alzheimer's Association, Us Against Alzheimer's. They have a brain guide that many of us in this community contributed to. It's in Spanish. You can call if you don't want to do it online. It's confidential. And in the final slide, I also want to just highlight, in the next slide, is a partnership. Yarisa mentioned we've been working together now over a year as a member of the National Association of Hispanic Nurses and also co-investigators at UCSF, Stanford, UIC, USC, and of course at my school at the University of Pennsylvania, looking at work that will leverage a national infrastructure of trusted organizations to truly change and move the needle on Alzheimer's disease research, to make sure that it represents communities like Hispanics and Latinos who again suffer disproportionately. So thank you so much. I look forward to the panel discussion and to any questions.
Oh, thank you so much. We're going to be starting our Q&A session now. So I'm going to ask our esteemed panelists to join me on the screen, and we'll start taking these questions. Our first question, and perhaps Dr. Pacheco can answer this one. What recommendation do you have for those who are not sure about getting the flu and or the COVID-19 vaccine?
Yeah, what was the first word that you mentioned?
What recommendation do you have for those who are unsure about getting the flu or the COVID-19 vaccine?
Well, one of the things they can do is just look at the statistics. You know, I mean, you don't have to look at statistics. Just look at the significant numbers of people who get the flu and what ravages they have. Not only, and I'm not talking only about mortality and damages, but also financial loss. You know, so they can call the health department and ask that question. You know, what happens? And I think one of the biggest things is it's not just what it does to your health. And by the way, flu can kill you, but it can also keep you from working, weeks, 2-3 weeks at the least, and with the risk of hospitalization, which means an incredible amount of bills, and the risk of passing the disease to older folks in the family or even younger or any other folks who have not vaccinated. So I think there's a lot of information that you can get from the health departments, from your physicians. Many of these hospital chains have the ANOVA system in Virginia and all that. They have on their website information about the flu. You can just put flu on ANOVA, for example, flu on Georgetown Hospital, and they have that kind of information available from credible sources.
Indeed. Thank you. Thank you for that answer, Dr. Pacheco. Now, I know we're kind of short on time, so I'm going to ask this question to any of our panelists. Christine, Dr. Perez, maybe you can chime in on this one about participating in research. What advice do you give to someone who's scared of participating in clinical trials, or maybe they think that research is too time consuming? We know the challenges. We heard Dr. Perez talk about the challenges, but what advice do you give someone who may be afraid to participate?
I do say because I recruit participants that my study, I spend a lot of time talking about the study and what benefits it has, the risk factors, how much time, they know, they're very well aware. I ask them to share their concerns. Some will talk about, well, I work these hours and I don't want to make a commitment if I can't keep it up. And so I try to alleviate that by, if indeed in the study they can attend when they want, depending on the issue. I tell them, ask lots of questions, ask lots of questions, think about it. You don't have to decide, and know that you can always change your mind. If you start a study and really don't like, it's interfering, causing whatever the issue, you can always withdraw and nothing will happen. You'll still receive the same benefits, treatment. You know, some are worried that, especially if it's their provider asking them to participate in a study, am I going to be treated differently? And I don't invite my patients to participate in my own research, but I know that that's sometimes, for patients uncomfortable. So I, just make sure that they know they can ask questions and that they could always change their mind.
Yes, and I do echo what Dr. Perez just mentioned. And it's okay to have a lot of questions. It's okay to feel a little bit like, ooh, scared. It's okay to feel all those feelings. I believe it's way best to, if you're interested in joining the health research, first read everything about the research that you are interested in joining, or you find interested, right, in joining as well, and learn about the benefits. Ask questions about the risk. There's no right or bad questions overall. So ask as much as possible any question you might have, because those questions are valuable and the researchers are always there to answer them. And again, it's important for us, I believe, for Hispanic and Latinos to be part of health research. This helps us in many, many ways, as Dr. Perez just mentioned in her previous presentation and my presentation as well. Participating in health research can find a cure or better treatments and prevention methods in certain diseases. This is sometimes the research takes a while. It's not from 2 or 3 days and we have the cure. It takes time. So feel free to find more information and always ask, as Dr. Perez just mentioned, healthcare providers. This is good for me. Do you have any recommendations? They know best, and they can guide you through the process.
Indeed, indeed. And I will just add to that people think of research in different ways. A lot of people think about clinical trials as, interventions using, medicines being injected and things like that. But there's different ways of participating in research. Some of them as simple as answering survey questions. So my advice is to learn a little bit more about the different options and get involved so that we could be a part of the solution. Now we are at time here, so we are going to end this webinar by thanking all of our attendees, our panelists, our sponsor Biogen, experts for being with us today for this frank conversation. And like to mention that for more information about upcoming webinars, please visit NHCOA's website and social media channels on Twitter, Facebook, and Instagram. And we will see you next time. Thank you for your time and for being with us today.
Thank you. Thank you, everyone. Thank you, Jessica. Bye.